Hi friends, variations in anterior chamber depth can actually change the feel and the experience of performing many steps during the cataract surgery, and this is what this video will depict. So let's start off with a challenging case like a small pupil where these changes become more pronounced. The first is in choosing a patient who's got a very shallow anterior chamber and a very small pupil, and let's see how the procedure goes in this case. Creating the clear corneal incision should be done very carefully so as not to damage the anterior capsule. This pupil, of course, needs to have some form of dilation. I'm going to use a pupil dilating ring device like the Gupta ring. Now, the insertion of the Gupta ring in a very shallow chamber actually poses several problems. So as you're injecting the ring, you need to protect it from inadvertently or accidentally touching the endothelium. It's very difficult to engage the loops onto the iris surface because the lens is bulging slightly forward. So the periphery of the anterior chamber are at a different depth. Therefore, when you are implanting a ring device in a shallow anterior chamber, it is best to first disgorge the ring into the anterior chamber and then tuck in each of the loops separately. So I'm going to use a bimanual technique, which is a very safe and easy technique, especially if you are not able to visualize the loops of the dilating ring. In this case, I'm not able to see the loop of the ring, therefore I use a Y pusher to push this device down so that the loop becomes visible. I then tag it and then engage it onto the pupillary edge. This is what I call the bimanual technique for insertion. It is safe and can be done in any type of eye with varying chamber depths. Use the Y end of the hook to push the limb so that the loop becomes visible, then tag on the limb. You can see how atonic the iris is, that it actually curls back on itself, revealing the posterior pigment epithelium. Once the ring is in place, you have to center it so that the square opening that you get in the pupil is well centered. It's not possible to use a Utrata forceps, or at least it becomes extremely challenging to use a Utrata forceps in very shallow chamber, and the best bet is to use a 26 gauge cystitome. Even then, you find that controlling the tearing edge of this rhexis is quite challenging in shallow anterior chamber. Cortical cleavage hydrodissection is then done. The nucleus management does not vary much between shallow chambers and deep chamber, except the fact that you have to be very careful not to get the pieces into the anterior chamber, as there could be endothelial damage that occurs. This is a gummy cataract, and many of these cataracts tend to look harder than they actually are, and that is the reason why I gave too much power to bury the phaco tip, which caused the nucleus to rotate while creating the first chop. Then I realized that this is a gummy sort of cataract, and therefore I give sufficient amount of power in order to get a good hold, and then I crack. Because it's sticky, you have to use extra lateral separation to get these pieces apart. So in shallow anterior chamber, do not try to prolapse the lens into the anterior chamber. Do not get too many pieces into the anterior chamber because the depth of the anterior chamber is less, and there is also a very likely chance that you would damage the corneal endothelium, and you may have to apply the phaco energy close to the endothelium. While disengaging the Gupta ring, remember this important fact: the two limbs are above the iris and two limbs behind the iris. So once you get one of the loops out, the loop that is from the same limb can be disengaged by rotation of the Gupta ring. To disengage the other loop, it has to be taken off from the pupillary edge, and then the rotation will work. Now let's look at another case of small pupils where the anterior chamber is deep. There is an ugly tuft of eyelash that is jutting out from there, and therefore I use my finger trap technique to tuck this eyelash in place. I have described this in another video as to how this technique is actually done. So let's proceed with the case. So the clear corneal incision is then performed. This is much easier to do than in a shallow anterior chamber. This patient is a high myope. The IOL power was 10 diopters. Just see how the Gupta ring goes into place. It's so easy to control the ring. In fact, in this particular case, I was able to engage all 4 loops at one go. This is not possible if the chamber is shallow, if it is not possible in many cases, but if the chamber is nice and deep, then you have a lot more control. This is also one of the reasons, if you're going to have a go at using these rings, always choose a patient who has got deep anterior chamber and small pupils, because it will make maneuverability much more easy. Also, the capsulorhexis can be easily performed using a uterine or forceps because of adequate anterior chamber depth. And you can see within these two cases that the performance of these initial steps has been much easier when you're operating on an eye with a deep anterior chamber than with a shallow anterior chamber. Always look at the anterior chamber depth under the slit lamp, because shallow anterior chamber is going to throw up much more problems during the management of several steps of the phacoemulsification procedure. Now this patient also had a similar grade of cataract. He had a gummy cataract, and the cataract looked harder than it actually was. In fact, it turned out to be a very soft lens, which was the reason why these bubbles happened. There are several causes for bubbles forming in the anterior chamber. One is a very loose sleeve which is attached to the phaco tip. The other is when you use too much power for a given nucleus grade. So I'm downsizing the nucleus into many small fragments. It's actually turning out to be a very soft cataract, and I have to exercise a lot of caution to chop this nucleus and not to have cheese wiring of the nucleus. So I switch my instrument at this point, and the reason for that is it helps me to move the pieces more easily in order to maneuver it to a suitable point in front of the phaco tip for removal. In soft cataracts, a Sinskey hook can do so many different maneuvers in order to push and pull and position nuclear fragments that gets thrown up during the chopping maneuvers. Finally, the epinucleus is removed. This patient, the high myope, I had to implant a 3-piece intraocular lens, and this is a sensor 3-piece lens going into place. This has to be done in a bimanual technique. Both hands are holding on to the injector. As the leading haptic comes out, you have to position the plunger in such a way that the lens is always facing flat. These lenses are extremely flexible and they will tend to tilt and turn inside the eye. You have to quickly position it with viscoelastic, and the IOL can be then inserted into the capsular bag using either a Y hook or a Cook lens device. Finally, removing the ring, remember that one loop is disengaged and you can simply rotate the loop which is in the same plane. To disengage the other loop, you have to pull it out. Again, by rotation, you can disengage, provided these two loops are in the same plane. So this concludes an analysis of anterior chamber depth and how it affects the phaco procedure. I hope this has helped you in your learning. Thank you for your attention.